Now let's go to the physical assessment of a pregnant
Yeah.
patient.
I have a question.
Okay.
Yeah, the 3P, the 3P,
Mm-hmm.
that the signs of pregnancy.
Yeah.
The under the probable, there is positive pregnancy test.
Yes.
Okay, that is confusing me.
Yes.
Shouldn't
So
shouldn't that be under the positive sign?
no. So not every positive pregnancy test means the patient is pregnant. So
Explain.
so for example, we're talking about the fact that um positive pregnancy test means the patient is surely pregnant, like doing an
Yes.
ultrasound and seeing a baby in the uterus, or palpating the abdomen and feeling that there's a baby in here, right? Now,
Yes.
the probable ones, they are
Yeah.
things which likely that the patient is pregnant. For
Yes.
example, if you go in to review what you call molar pregnancy,
Mm-hmm.
molar pregnancy, there's a kind of molar pregnancy where it is just moles in there, like
Mm.
circular stuff. There's no baby, nothing, but the pregnancy test is positive.
So
You,
does that mean that the molar pregnancy produces pregnancy hormones?
yes, yes. And even in
Okay.
males, you can have a male with testicular cancer and the
Mm-hmm.
pregnancy test will be positive.
Okay.
Yes. So
Okay.
basically, the positive ones are that if you see it, that means the patient is pregnant. But the probable one is it may be that the patient is pregnant, or it may be that the patient is not pregnant.
Okay.
So that is
So
why. Mhm, sorry.
positive. Hello, can you
Yeah.
hear me?
Yes, I can hear you. Yeah.
So the positive sign has to be the presence of life or a viable fetus
Yes.
only.
In the uterus. Yes.
Okay. All right.
So that one, and
Thank
in
you.
fact, in the mock, you will see that we will be quizzing you on that as well a lot. Yeah, because
Okay.
it's very important. It confuses a lot of candidates in the exam. Okay, sure. So let's look at
Thank you.
physical assessment of a pregnant patient during the initial prenatal visit. Okay, that was a very good question. So when the patient comes, after you've taken your history, what are you going to do so far as physical exam is concerned? You want to check the fetal heart rate. As I said, when the fetus is very little, between 10 to 12 weeks, you can't use the regular fetoscope. So you can use the Doppler and you can pick it up around 10 to 12 weeks. And then the fetoscope, you can pick it up from 17 weeks going. Okay. Fetoscope, you can pick it up from 17 weeks going. Now, for normal fetal heart rate, okay, for normal fetal heart rate, it is usually between 110 to 160 beats per minute. 110 to 160 beats per minute. And then you also want to do the fundal height. That is measuring from the pubic symphysis to the top of the uterus. That helps you to estimate the gestational age of the baby. But we also learned today that there are a lot of things which can affect that. For example, if the amniotic fluid is too small or too much, if the fetuses are more than one, right? If there is things like uterine fibroids as well. Now, you also want to do some vitals like the blood pressure because of the risk of hypertension in pregnancy and preeclampsia. You want to check the pulse because of the effect of the thyroid gland. Because if the thyroid gland is hyperfunctioning, the pulse will be high. You want to check the respiratory rate. You want to check the temperature to find out, does the patient have any infection going on, right? You want to check the height. You want to check the weight of the patient because there's a specific amount of weight which patients are expected to have depending on the gestation. You want to check their thyroid function because I've said that thyroid function usually goes up when the patient is pregnant. And then you also want to check the heart and the lung sounds because eventually when the patient is pushing, the patient will need strength from the heart to do the pushing. And you want to check the size of the uterus. Does it correspond with the gestational age? And you have to know the things which can cause disparities in the size of the uterus as compared to the gestational age, if the mother is small, if there's more than one baby, even if the mother has diabetes and the baby is big, we call that fetal macrosomia. If the mother has so much amniotic fluid or very little amniotic fluid, if there's a lot of like uterine fibroids, trouble, right? And then you also want to even examine the muscles of the pelvis and how adequate is the pelvis for delivery. Because if the pelvis is too small, the fetus cannot come out. So these are the things you want to pay attention to. And then while we are doing this, let's assess the labs in a pregnant patient in the first trimester as well. Or in the first visit, sorry, the first visit. The labs to assess a pregnant patient in the first prenatal visit. So first, you want to do hematocrit and hemoglobin because you don't want a pregnant patient to be anemic, right? Because they need to get blood supplied to the baby as well. You want to even know the blood type of the pregnant patient, the blood type. Because when we go into resource isoimmunization, you'll understand it. But for now, just take the blood type. And then you want to know even the RH, the resource antibody. Does the patient have any antibodies there? You want to check rubella titer. You want to check tuberculin skin tests. You want to check renal function tests. You want to check urinalysis and culture. Why? Because if you have a patient who is pregnant and who has a UTI, it can lead to preterm labor. It can lead to, all sorts of complications. You also want to screen them for STIs. You want to do a pap test. You want to do an HIV test. These are the labs you do on the first visit. But we will discuss all the details in a different class. For now, I just want you to know that these are the labs you do in the first prenatal visit. All right? Now, so what is the nursing care during the subsequent prenatal visits? What's the nursing care? Number one, this one is very important.
Excuse me, sorry, please, can you go back to the last slide?
Sure, I'll go back.
The labs, yeah, thank you.
These are the labs you do in the first prenatal visit. Is that okay? Can I move on now?
Thank you, yeah, that's okay, you can
awesome.
move on.
Awesome. So part of your NCLEX preparation, you must also know the frequency of visits for the pregnant patient depending on the gestational age. So if you're even sleeping and I wake you up and I say, the patient is 32 weeks, how often should the patient visit the doctor? The patient is 16 weeks. How often should the patient visit? The patient is 39 weeks. How often? So let's look at it. In the first 28 weeks, the patient should see the doctor every 4 weeks, unless there's a different reason to see the doctor. So we are talking about normal pregnancy, no concerns. First 28 weeks, the patient must see the doctor every 4 weeks. Between 28 and 36 weeks, the patient must see the doctor every 2 weeks. And after 36 weeks to delivery, the patient must see the doctor every week. Please, should I take it again? First 28 weeks, see the doctor every 4 weeks. 28 to 36 weeks, see the doctor every 2 weeks. And 36 weeks to delivery, see the doctor every week. Is that clear? So remember, 28 and 36. Before 28, every 4 weeks. Between 28 and 36, every 2 weeks. After 36, every week. Every 1 week, okay? Not every 1 week. Let me correct that right away. Every 1 week. After 36 weeks, every 1 week. That is it. Okay?